This is a great question for you, particularly not just as you specialize as a therapist in the cervical spine or the spine, but even prior to being a physical therapist and your work as an athletic trainer. There's been a few studies that show that increasing neck strength decreases the concussion risk by fourfold. And so I get a lot of questions of, well, these athletes, they have big, strong neck muscles. What they don't have is the intrinsic. So could you elaborate kind of your experience from athletic trainer, physical therapist, about the misconception about someone being strong in their neck and having weak intrinsic cervical muscles?
Absolutely, and it goes well even from that point when we're talking about weak intrinsics. Even just ligament instability. Just because someone has a big, thick neck or huge shoulders does not mean that they have a stable shoulder, right? They could be grossly unstable in their shoulder. So you have to go in and assess all those things separately. That's why we look separately at deep neck flexors and deep neck extensors. And then we do a endurance test or a test, that involves weight. And so appearances is anything. I used to kid around with my athletes, especially my track and field people, that their muscles just were full of air. And because when I'd actually look at their musculature, they were so weak, but they were just these huge muscles and a lot of times musculature that is in dysfunction, right? You don't have good neuromuscular control. It doesn't necessarily mean it's weak. It may mean that it's just, and I hate to use the word, but may mean that it's not turned on or it doesn't exactly know what to do. And once you work with the muscle, it's like, all right, I got it here. I know what to do now. You can just do it sometimes like this, especially when we're talking about athletes. Okay, but you have to understand that when there's been injury, that is a protective mechanism that we've seen that a lot with the musculature goes into dysfunction. So when we raise our arm up, we should have a feed forward, right, of our musculature to stabilize our spine. That may go away totally. And you have to assess that to make sure that the musculature is doing what it actually needs to do. And sometimes it's just prompting it to get it to come back and to fire proper.
Yeah, and I think that's one of the through the years being able to work together and all of the vestibular therapists participating in this. When people have movement related dizziness, it's a big indicator it's their inner ear, and so what they rarely meet people that want to be dizzy. So what they do is they stop moving their head, their muscles, their overactive activation of the muscles and in order not to be dizzy. So we battle between, okay, I'm going to work on the neck, but then when I do, it increases their dizziness. So now it comes back to, that challenge of, we know we need to work parallel, but when do we decide to choose this and when do we choose that? Do you have any kind of words of wisdom when you're treating that kind of combined of movement related dizziness and the cervical spine?
If you're talking, what the word that just stuck out in my head and I got lost on when you said it was the fact of overprotective. And what we know is that muscles change in what their function are, right? So we know that the long lever muscles actually start to function and try to function as a segmental stabilizer. And that's where a lot of this comes into play. And so basically it's getting that, retraining the person as far as precision and getting the muscles to precisely control the segments and be turned on there and have the other muscles, the sternocleidomastoid, some of the scoleni, levator scapula, to decrease their function as being the stabilizer of the neck. They're a prime mover, and it's basically just to learn to know how to separate that and how to assess that.